From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology Web Editor. Today, I have with me Dr. Andrea Schneider, and we're discussing her work titled Posttraumatic Epilepsy and Dementia Risk. Dr. Schneider is an assistant professor of neurology in the Division of Neurocritical Care and also assistant professor of epidemiology and biostatistics and informatics at the University of Pennsylvania. She also has deep interest in traumatic brain injury and also participates in the University of Pennsylvania's Traumatic Brain Injury Program. Dr. Schneider, welcome to our podcast.
Thank you so much for having me today. I'm excited to talk with you about this.
Yes, this is tremendous work that you're doing with your colleagues. And I wanted to get a little bit of a general sense of what we currently know about post-traumatic epilepsy and the difference between that and non-traumatic epilepsy.
Yeah, no, great question. And that's one of the big things that motivated this work, because with respect to post-traumatic epilepsy, we don't know enough, and we certainly don't know as much as we do about epilepsy. So what we know is that post-traumatic epilepsy has been associated with short-term worse outcomes after injury. So worse functional outcomes, worse psychosocial outcomes, and worse cognitive outcomes.
Mm-hmm.
But there's really a lack of understanding what happens long-term after a diagnosis of post-traumatic epilepsy.
Yeah, do we understand the pathophysiology of what happens within post-traumatic epilepsy and this perhaps connection with cognitive decline?
There's still a lot more to be learned. I think that there is growing evidence that epilepsy as well as traumatic brain injury are associated with long-term cognitive outcomes. And there's also been some recent suggestion that the underlying mechanisms for both may be neurodegenerative in origin.
Mm-hmm, mm-hmm. So what did you and your colleagues set out to look for? What did you think initially? What was your hypothesis? And what questions were you specifically trying to answer?
So given that we know that both epilepsy and traumatic brain injury are independently associated with increased dementia risk over time, we sought to investigate if post-traumatic epilepsy was associated with even greater risk. So compared to epilepsy alone, compared to traumatic brain injury alone, and compared to individuals without either.
Did we know about specific traumas and the association, or is this in general?
So really in general, so in our study, we did investigate the number of prior injuries that individuals had. So did they get epilepsy after, say, a first injury versus a second?
Mm-hmm.
And then we did do a sub-analysis where we looked by injury severity, whether it was a mild injury or a moderate or severe injury.
So take us through your methods and the parameters that you went through in order to find out these associations and the risk.
Yeah, absolutely. I'll first start by just describing the study. So the study population itself is called the Atherosclerosis Risk in Communities, or ARIC study.
Mm-hmm.
This is an ongoing longitudinal cohort study that started in 1987 to 1989, when they recruited nearly 16,000 individuals from 4 U.S. communities. These individuals have been followed ever since. They've had repeat in-person visits, telephone follow-up calls, and then their data is also linked to Centers for Medicare and Medicaid Services data. So when we defined head injury was defined by both self-report questions, asset study visits, and also by linkage to hospital surveillance of all study hospitalizations, as well as linkage to the Centers for Medicare and Medicaid Services data.
Mm-hmm.
So we use the Centers for Disease Control's definition for traumatic brain injury to be consistent, and combine that with our self-report data to define head injury. And so we also considered the number of head injuries, whether they had 0, 1, or 2 or more over study follow-up, and if their first head injury was mild versus moderate, severe, or penetrating. To define seizure or epilepsy, we define this using data from the ERIC hospitalization data, as well as the linked Centers for Medicare and Medicaid data using ICD-9 and 10 codes.
Mm-hmm.
And then what we did to define post-traumatic epilepsy was we combined those two definitions, and we said that post-traumatic epilepsy is any seizure or epilepsy diagnosis which occurred greater than 7 days after a diagnosis of head injury.
Right.
Because within 7 days, it may just have been in the setting of the injury and that. So this is consistent with other definitions of post-traumatic epilepsy.
Exactly.
And for our outcome of dementia, the ERIC study actually has a 3-level dementia ascertainment protocol.
Mm-hmm.
And so it incorporates 3 levels of data, so including in-person intensive cognitive evaluations, telephone data from individuals who were not able to attend the visit or who died prior, getting informant information. And then also we combine that with ICD-9 and 10 codes.
Okay, I see. Was this the post-analysis where we're looking at data that was kind of previously collected?
Yeah, so all of this data was previously collected. So follow-up extended from study baseline in 1987 to 1989, which was the visit 1,
Mm-hmm.
through December 31st, 2019.
Were there any particular confounders that you were worried about when extrapolating the data and thinking about the results?
Yeah, so we considered a number of statistical confounds. So in our statistical models, we included age, sex, a combined race and field center variable. We also included education, military veteran status, smoking, alcohol consumption, diabetes, hypertension, and then ApoE4 genotype.
Individuals can have post-stroke epilepsy. Was that something that you accounted for? Because that's a type of brain trauma in a general sense, but probably not what we're defining here.
Absolutely. We wanted to consider stroke in a different way, in addition to mortality, right? Because I think that some people can have a traumatic brain injury and die prior to ever experiencing a seizure. They may not have made it to 7 days and that sort of thing.
Mm-hmm.
So in addition to our main analysis where we perform Cox proportional hazard models, we did a sensitivity analysis where we accounted for these, what we call competing risks of mortality and stroke. And we use fine gray proportional hazard models to account for that.
Mm-hmm. Tell us about what you found.
So in our analysis, we analyzed our exposure variables as time varying, meaning that over the course of follow-up time, people were allocated into a TBI status group and from there to a post-traumatic epilepsy group or to an epilepsy group, because at baseline, nobody had any of these exposures.
Mm-hmm.
So what we found over up to 30 years of follow-up is that there was nearly 2,500 incident cases of dementia. And in our statistical models, post-traumatic epilepsy was associated with approximately 4 times increased risk of dementia compared to no seizure and no epilepsy alone.
Mm-hmm.
This was statistically significantly greater compared to individuals who had just a traumatic brain injury and just a seizure or epilepsy.
Mm.
Once we accounted for the competing risks of mortality and stroke, there was still a substantially increased risk. Post-traumatic epilepsy had 3 times the risk compared to individuals with no traumatic brain injury and no seizure or epilepsy.
I always think about this in a clinical sense, especially if you're part of a traumatic brain injury program. What do you take from that association? Because there's obviously significance there. And I would think that there would be some sort of measures put in place for prevention as well as particular management of these patients. I'm wondering if there's a difference between how we treat those patients versus epilepsy alone, etc.
Yeah, great question. And I think, there's really 2 big implications in my mind from this work. The first being that primary prevention of head injuries is really, really important, right? You cannot get post-traumatic epilepsy without a prior head injury. So,
Right.
Public health measures, wearing helmets, motor vehicle safety, all of these things are still really, really important. Our results underscore that. But second, I think that among those individuals who do have traumatic brain injury, what we've shown is that those who go on to get seizures are at substantially increased risk of dementia compared to those who don't. And that's important. So I think in this area, we really need further research. We need further research into how can we identify the people who will develop epilepsy versus who don't. Certainly, there's many risk factors for it, including injury severity and other factors. But how can we do that better? Second, what are the mechanisms? And I think that this is where we need to translate back,
Right.
Go back to the lab, go back to the animal models to gain some more insight into disease mechanisms, because I think only then will we be able to start talking about treatment.
Right. Yeah, the mechanism is really important. I thought about that because there are certain therapies that you can implement, especially in individuals with cognitive disease. If you think about just cognitive disease in general, what do we tell our patients in that sense? But now, how do you treat someone who's having that as well as with epilepsy? Do you have, as part of a traumatic brain injury program, what can you tell general neurologists who maybe aren't a part of programs like this? What can you tell them about managing a patient with post-traumatic epilepsy? What are the main tenets of therapy and counseling for that patient population?
Yeah, so I think that much of it, aside from the seizures, is the same as those with just traumatic brain injury, right? I think
Mhm.
that clearly once you have post-traumatic seizures, some of those patients are seen, if they're fairly simple and the epilepsy can be easily controlled, seeing them by general neurologists. But I think consulting with an epileptologist at times may be necessary. I do think that future research should be done to determine if, say, more severe post-traumatic epilepsy, if you have more seizures or drug resistance, so that we know if perhaps that is at risk for adverse outcomes. But otherwise, largely traumatic brain injury treatment is symptomatic, right? We
Mhm.
treat the headaches, we treat the mood symptoms, we do physical therapy to treat any vestibular issues, all of that sort of thing. So I think a multidisciplinary approach is often needed and helps a lot.
Dr. Schneider, thank you so much for joining us on the podcast today. It was wonderful speaking with you about this, and I look forward to follow-up studies, diving deep on mechanisms so that we can help this particular patient population.
Thank you so much for having me. I'd also like to just take a moment and thank all of my co-authors and also express gratitude to the participants in the ERIC study who allowed us to collect data and make these important discoveries.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This is Dr. Cynthia Armand. Thank you for listening.